Hi, everyone. Welcome to today's Student-Led Journal Club and Case Studies Seminar. My name is Anne-Marie Hayes. I'll be introducing our speaker today, student Dr. Erin Graves. Student Dr. Graves is a second-year medical student at Kansas City University. Erin moved to Kansas City from Colorado, where he worked as an EMT and Research Assistant in the Emergency Department at Denver Health Medical Center and obtained his master's in toxicology. He is currently a member of Dr. White's lab in Kansas City and has a wide array of research interests. He spends his free time exploring Missouri with his dog, and today he'll be presenting on Thromboelastogram use in trauma-induced coagulopathy overview. So with that, student Dr. Graves, the floor is yours.
Thank you, Anne-Marie. As you mentioned, I'll be talking today about the use of thromboelastography in trauma-induced coagulopathy. Just off the bat, to give you an idea of what thromboelastograms are, or TEGs, as I'll be referring to them, they're blood tests used to identify the coagulation ability of a patient. Why am I interested in this topic? As Anne-Marie mentioned, prior to my time at Kansas City University, I worked as an EMT in the ER of a fairly busy level 1 trauma center for the last 4 years. My time there was educational, and when I left for med school, I hoped to answer some of the questions that had lingered. One such continual question that I was curious about was the use of TEGs in our severely injured trauma patients. I knew the basic science behind TEGs, but I wanted to do a deeper dive and better my understanding. However, to explain why TEGs and viscoelastic hemostatic assays are important in trauma, I first need to talk about trauma-induced coagulopathy. So I hope that you all find this topic as interesting as I do, and you're able to take something away from it today. So some quick background of what we're going to be talking about. We're going to do an overview of trauma-induced coagulopathy, what it is, some major players. We're going to talk about how thromboelastograms actually work and how they are useful in the treatment of trauma patients. Some background on how trauma affects people in the United States and worldwide. So in the US, trauma is the leading cause of death for adults and children under the age of 44. Approximately a quarter to a third of these deaths occur from hemorrhage. Of that, approximately 50% are considered preventable. That is to say, given some proper intervention, pre-hospital or hospital, these deaths could possibly be avoided. Most hemorrhage deaths occur within 24 hours of injury, and most of those occur within 3 to 6 hours. TBI makes up a large percentage of these traumatic deaths, and those present their own coagulopathy issues. But we're going to talk real quick about what leads into these bad outcomes on severely injured trauma patients. So many of you might be familiar with this, but this is what's known as the lethal triad. However, it's probably better to call it the lethal diamond now, as it's been expanded. The lethal triad are 3 presentations in severely injured trauma patients that correlate with higher rates of mortality. The traditional lethal triad consists of coagulopathy, metabolic acidosis, and hypothermia. This, as we're going to talk about, will worsen trauma-induced coagulopathy and are the pillars to trauma care. But that being said, trauma-induced coagulopathy can be present in a patient without these. Now, metabolic acidosis will, a drop in the patient's pH will disrupt platelet and coagulation enzyme activation. Hypothermia affects calcium binding and platelet dysfunction. And calcium, which has been in the recent years added to the lethal triad to make the lethal diamond, calcium is necessary for proper coagulation and is worsened in hemorrhage. Furthermore, the use of blood products, which is commonplace for trauma resuscitations nowadays, carries citrates within the packaging, especially platelets and plasma. And citrates act as calcium chelators, worsening hypocalcemia, contributing to this positive feedback loop of coagulation, metabolic acidosis, hypercalcemia, and hypothermia. So what actually is trauma-induced coagulopathy? So to start off, I'll say trauma-induced coagulopathy, or TIC for short, is a large topic. It covers a lot of ground, and it's a fairly newly defined disorder. Additionally, there's been incredible advances due to the hard work of a lot of people and researchers, but there's still a lot that's unknown. And because of that, I'm just going to be hitting the main points that I think are important to talk about viscoelastic hemostatic assays later on. So there is no standard definition, nor is there an obvious dominant mechanism of TIC, which makes sense if you think about the heterogeneity of trauma. That is, no one patient is sustaining the exact same injury. My definition in reading of the literature that I came up with is that TIC is impaired coagulation due to dysfunction in hemostasis, anticoagulation, and fibrinolysis following a traumatic injury. This occurs in approximately 25% of severely injured trauma patients, and early recognition is incredibly important because it's associated with an incredibly high mortality rate. So what does TIC actually look like? Well, it runs a pretty wide spectrum of how it can show up and what the phenotypes might look like based on the injury. So on one end, you might have hypocoagulability associated with a decrease in thrombin, fibrinogen, platelet dysfunction, and high rates of fibrinolysis. Additionally, you might see hypercoagulability due to a surge in thrombin, increase in fibrinogen, high activation of platelets, and a decrease in fibrinolysis. Now, these are not one or the other. They can be overlapping at times. You can have one happen and then another happen. And as we'll talk about in the next slide, there's sort of no hard and fast rule for what patient is going to experience which phenotype. So in talking about the timing of TIC, the early versus late trauma-induced coagulopathy is defined generally by hypocoagulability versus hypercoagulability. That is to say, early TIC tends to look like hypocoagulability, hemorrhage, shock, whereas late TIC is more associated with hypercoagulability and the presence of thromboembolisms resulting in organ damage, large PEs, DVTs, things of that sort. But as I kind of mentioned before, these are not hard and fast rules, and different coagulopathies can occur at different states, sometimes unpredictable, without being able to be easily predicted. I think one obvious question that would arise for most people is TIC just a form of DIC? And this seems to be a point of contention between researchers in this field, but most review studies that I've looked at this point indicate that TIC has a different unique mechanism than DIC, primarily, but not only, related to the initiation of TIC via tissue factor. So major players of TIC are, and this is by no means a comprehensive list, but some of the well-known and kind of major players up to date are the increase in active protein C, which is associated with worse outcomes in trauma patients. Platelet dysfunction, which is to say, even in trauma patients who are severely injured and have an appropriate platelet count, there can be an inability of the platelets to correctly activate, meaning the issue is not the platelets themselves, but some downstream or upstream effect. As I previously mentioned, tissue factor, which is exposed upon endothelial damage, which obviously happens in trauma, will result in an activation of coagulation. And thrombin can play a role in the hyper or hypocoagulation. Early lack of thrombin can delay coagulability, whereas an excess of thrombin may be released, resulting in hypercoagulability. Fibrinogen can be depleted rapidly due to blood loss, hypothermia, acidosis, and this is also associated with worse outcomes. In particular, to note, one reoccurring theme of trauma-induced coagulopathy is this association with hyperfibrinolysis. That is, even when clots form, they can break down quickly and rapidly, resulting in uncontrolled bleeding from sites, not only at the site of injury, but from non-injured sites in the trauma patient. So the question becomes, how do we identify trauma-induced coagulopathy early, and how do we manage this dynamic coagulopathy in an effort to reduce morbidity and mortality? So as I think most people are aware of, we have the conventional coagulation tests, PT, PTT, INR, platelets, and there's nothing wrong with these. They obviously contribute greatly to the care of the patient, but they're also limited in telling the full story, particularly, as I mentioned, in regards to fibrinolysis. As such, it's necessary to employ the use of additional tests, which is where I think viscoelastic hemostatic assays come in. So, in addition to conventional coagulation testing, the use of viscoelastic hemostatic assays in trauma patients has been utilized for some time. In particular, the TEG and the ROTEM. We're going to be talking about TEGs. ROTEMs are primarily used in Europe and somewhat in the military, but TEGs are predominant in civilian hospitals across the United States. So I'm going to focus on those today. It should be noted that viscoelastic assays are commonplace in cardiac and hepatic surgeries, but there is this discussion about what the role for them in trauma patients are. So what is a TEG? As I mentioned real briefly at the beginning of the presentation, a TEG is an in vitro test to measure the ability of an individual's blood to clot and lyse. Rapid TEGs now can result in approximately 15 minutes. And what we're able to tell from this is how rapidly and strongly the clot is formed, how quickly it's broken, and from that, interpret what might be missing, dysfunctional, or insufficient in the patient, and then replenish that. So in terms of how a TEG actually works. So it was developed some time ago, 1948, by Dr. Helmet, and it was actually used briefly in Vietnam and has come back into service in terms of its usefulness in trauma patients in the last, I think, 20 or 30 years. And essentially, in order to get the image and numerical data from a TEG in order to treat the patient, a sample of blood from the patient is taken. It's placed in a heated sample cup with calcium chloride, which recalcifies the blood after its exposure to citrate. And you also add coalin and phospholipids, which activate the intrinsic and extrinsic pathways. The sample is then oscillated, and as the clot is formed, a pin inside of the blood transfers an electrical signal through the transducer, and it forms an image. And what that image will end up looking like is this, which I promise you looks initially confusing, but it's actually much more easy to read the longer you look at it. So the resulting image is broken down into coagulation and fibrinolysis. If we look on this right side, I'm going to talk about some of the main aspects of this and why they're important over the next few slides. So the R time is the time from when the sample begins to oscillate to when the actual clot formation occurs. And then once the clot formation occurs, we have the K value, which is the initial clot formation strength, which is part of the kinetics of the clot. So it's a measurement from start of the clot to a 20 millimeter clot formation. The angle is similar in that it's measuring kinetics, but on a beyond the 20 millimeter mark. And the maximal amplitude, as it might imply, is how strong the actual clot is overall. And then the here it's referred to as the A30. Most places call it the lyse 30. This is from the time of the maximal amplitude until the time that the clot begins to break down or or rather, sorry, the amount of clot lysis after 30 minutes. So this is measuring how quickly the clot is actually breaking down. So what does this actually look like in practice? So if we were to take a tag or rotum from one of us today, it will probably look pretty similar to this one on the left here, number 1. So this is a normal tag. As you can see, there's the R time is very small, so there's rapid clot formation. We have a strong, healthy K and A angle, and then a big maximal amplitude, meaning quickly formed, strong clot that's not breaking down quickly at all. On the right side, we can see a dysfunctional, dysfunctional clotting occurring. So compared to the left, we have a longer R time, meaning a prolonged start to coagulation. We can see the K value is prolonged, meaning there's resistance to form that initial clot once it does get going. The maximal amplitude is significantly smaller, meaning when it does form, even at its strongest, it's not going to be the strength necessary to maintain proper hemostasis. And then as you can see, the clot begins to lyse pretty rapidly and degrade, meaning that continued bleeding will continue. Hyperfibrinolysis, which is this rapid breakdown of clots, is very much associated with worse mortality rates in trauma patients. So in hospital, these would actually be given a numerical value. You would be able to look at the image if you wanted, but these are given in a numerical value to be measured against standard values. So how we were able to use this, again, if we look at the R time, the K time, the angle, the maximal amplitude, and the time from maximal amplitude to how much has lysed in 30 minutes, we can determine what part of the clotting process is deficient or is missing something. That's to say, if we have a prolonged R time, we have a dysfunctional or insufficient coagulation factors, and the patient's going to require additional is going to require FFP infusion to make up for the lack or loss of coagulation factors. Similarly, if you have a prolonged K time, this is associated with dysfunctional fibrinogen or thrombin, rather, meaning the treatment will be addition of fibrinogen or cryoprecipitate. Similarly, the alpha angle, which is similar in terms of the kinetic value that the K time gives. If this is decreased, meaning it's taking longer for this clot to form to full strength, we will see it'll most likely be due to a deficiency in fibrinogen, meaning again, treatment will be cryoprecipitate or fibrinogen. If we see a decrease in the maximal amplitude, meaning we have a clot that is not as strong as it should be, this is primarily associated with lack of platelet activation or platelet count, and the treatment will be to give the patient platelets. And then finally, if we're seeing rapid fibrinolysis, meaning an increase in the lysis of the clot, we'll give TXA or tranexamic acid, which will inhibit the breakdown of clots. I thought this was a neat graphic to show various phenotypes and the resulting tag. So for example, here we have a normal tag, pretty rapid R time, quick onset, good maximal amplitude, and a lack of fibrinolysis. Whereas if we go down, we can compare to anticoagulants, which as we'd expect would have a prolonged R time, so a long time for clots to actually occur, and then looks like slightly less maximal amplitude, compared with this rapid high fibrinolysis, which even after the clot forms, it breaks down very quickly, or hypercoagulation, where we see the opposite effect, a wide maximal amplitude or a big strong clot that is unable to break down. And then interestingly, the phenotype of DIC, where we have a rapid clot formation, and then we get a drop off indicating fibrinolysis or breakdown as the patients go into a fibrinolytic state. So the question still being asked, is using TEGs to drive trauma resuscitations better than conventional coagulation therapy, or using a fixed ratio, meaning when a trauma patient arrives to the ER, they're given some fixed ratio of 1-to-1 blood to plasma or 2-to-1, or depending on what the hospital protocols are. A previous randomized control trial that looked at survival outcomes using TEG versus guided transfusions against conventional coagulation testing found that there were improved survival outcomes. That being said, the primary systematic review that I used for this paper did throw some uncertainty on the efficacy of TEGs versus fixed ratio resuscitations. And there was a multi-country, multi-center study done in 2020 that also kind of threw a wrench in the TEG or viscoelastic hemostatic assay versus conventional coagulation guided therapy for trauma patients, as they found no difference in primary and secondary outcomes between the two groups. So with that being said, TIC is obviously a complex, evolving topic. Given the prevalence of traumatic deaths worldwide and in the US, there definitely needs to be an increase in research and funding. Viscoelastic assays are a valuable tool for caring for severely ill trauma patients, and there need to be more studies, in particular, I think, randomized control studies to determine the efficacy and the best use of viscoelastic hemostatic assays. And those are my references, but please ask me for any questions.
Awesome. Thank you so much, student Dr. Graves. Wonderful presentation. As you just said, if anybody has any questions, feel free to raise your hand in Zoom or unmute and go for it. Or if you can't chat, feel free to also type it into the chat and I'll read it out loud. Dr. Johnson, I think I saw your hand up.
Yes, ma'am. Thank you. Aaron, that was outstanding.
Thank you.
The quality of your presentation was spot on. Your explanations, this is a complicated area, but your explanations were very much appreciated, and with some simplistic take-home messages. I have a couple areas I'd like to go over with you.
Yeah.
And one of them would be in the field of differentiating this bleeding and surgery problem, meaning if it's a problem that something's been lacerated or something's broke, and it makes sense to assess the coagulating cascade pre-op.
Mm-hmm.
Does this enhance your ability to rule out some coagulopathy quickly, to jump right in for surgical intervention? You with me?
Yeah. I'll answer to the best of my ability. Obviously, I'm not a surgeon.
I understand. I'm
but
just trying to get the clinical application.
Yeah. So
Operate or to treat conservatively with supportive care.
Sure. I think, again, with the heterogeneity of trauma patients, it's somewhat dependent. I think this is not the end all be all by any means, but it's a guiding therapy from my experience of what I've seen. That's to say, if an individual has a major traumatic injury requiring surgical intervention, their coagulopathy isn't going to move that one way or the other, but it'll help guide the therapy both in surgery and in the ICU to prevent them from continuing to bleed or make clots. But one thing I might not have hit on as well as I'd like to, so if you do have, let's say, some massive penetrating injury that is taken up to the OR and the damage is packed or the majority of the bleeding is stopped, even the issue with trauma-induced coagulopathy is that you can have systemic hypocoagulopathy even from sites outside of that initial spot of injury, leading to these major areas. So I think where it seems to come in handy is a little bit long-term resuscitations, both as the patient is either going to the operating room or going to the ICU, and you're getting real-time data saying we need to give platelets or we need to give cryoprecipitate or plasma or what have you.
Yeah, it's a team effort and to try to stop whatever's going on. So I appreciate your approach to that and your explanation, and I really enjoyed your talk.
Oh, thank you.
Just to reiterate what Dr. Johnston was saying, I agree. You did a really good job of bringing it down to a base level and then explaining off of that the different complicated aspects of each part. So yeah, thank you so much again. Thank you everybody who joined us today on their Friday evening.
Thank you.
Have a good weekend, everyone.
Have a good one.